Hi, my name is Natalie Bodine and I'm the Quality Improvement Specialist with the CHIC project. Today I'll be talking about quality improvement. What gets measured gets done. So what is quality improvement? Quality improvement is the method of evaluating and improving processes of patient care. We're really focusing on the system as a whole and not just on individuals in a practice. It narrows the gap between what clinicians think and know and what they do. Essentially, everything that impacts the care a patient receives in a medical office involves many people. It involves the front office, the back office, providers, medical assistants, and administrative staff, and including the right people is critical. So how do you do quality improvement? We are going to be following the model for improvement, which is a roadmap to improvement. Our source comes from the Institute for Healthcare Improvement. And there are two main parts, your aims, measures, and changes, and your PDSA, or your Plan, Do, Study, Act cycles. First, the aims, measures, and changes. The aim, what are we trying to accomplish? What issue is your practice trying to address? The measures, how will you know that a change is an improvement? First, you need to measure it, and then you need to measure it over a period of time. The changes, what change can we make that will result in an improvement? And you can use the PDSA or progress form to measure these changes, which are small, rapid cycles of change. Let's talk a little bit more about PDSA cycles and developing those changes. Plan. Questions and predictions. This will include the who, what, when, and where. It'll also include creating measurements. Do. Implementing the plan. Documenting problems and observations. Study, what worked, what did not work. Compare the data to the predictions. Summarize what you learned. Act, note what to do differently in the next cycle. What are your next steps? Do you adapt, do you adopt, or do you abandon? And finally, cycle. You will do over and over again until the intended benefits are realized. This next form we are looking at is the Plan, Do, Study, Act, or the PDSA form. You can see there are many main sections to this form. The top section is your aim section. You're going to lay out what you plan to do, what your practice plans to do. The Plan section, what issue does your practice want to address? This is the who, what, when, and how. Then there's the Do section. What change are you going to make to impact the issue that you're working on? The Study section, what happened after making this change? What observations did you see? The Act section, what are the next step for this change? Will you adapt? Will you adopt? Or will you abandon? And then on the bottom you can see two additional sections, one for partner feedback, to gather any kind of comments or feedback from your quality improvement team. And the last one is support needed. Is there any support needed that would help you further along in making the improvements you want in your practice? For this Immunization Learning Collaborative, we will be looking at 4 core measures. The first measure is the 2-year-old immunization completion rate for children aged 22 to 26 months, which will be done through a COCASA report. The second measure will be looking at the percentage of missed opportunities, which will be done through a monthly chart review. The third measure will look at percentage of patient medical encounters that have assessment of current immunization status documented. That too will be done through a monthly chart review. The last measure will be looking at the percentage of patient medical records with follow-up for next immunizations documented, and that will be done through monthly chart reviews. The next slide looks at the percentage improvement matrix. Our overall goal for the project is that by the end of the project, all practices will meet or exceed 75%. So depending on where you start, peer-to-peer data suggests an increase of 15% is achievable for most practices, starting around the Idaho state average of 65%. We will also be looking at 3 process measures for this learning collaborative. The first will be the number of reminder recalls monthly for children 18 years of age or younger with missing immunizations. The second will be the number of Irish reports or queries done monthly, and this will be done by the Idaho Immunization Program. The third process measure will be the number of V64 codes that are used monthly. Our balancing measure for this project is the percentage of invalid immunizations given by the practice. And a balancing measure is an unintended consequence of quality improvement measures. So you may have short-term costs, but there should be long-term benefit. So for this immunization learning collaborative, we have 4 project deliverables. The first, to develop and document an office immunization policy or standardized order set. The second deliverable will be to develop and document an office policy for patients not immunizing on the regular schedule, delayed, or refusing all. We would also like you to include your immunization refusal form if using one. Third, to develop and document an office process for patients with unknown or incomplete immunization status that includes steps the practice will take to obtain records and/or recall patients to administer undocumented doses of vaccine. Lastly, to develop and document a recall reminder process. The next slide shows the chart audit form that will be used for the baseline audit and also the monthly chart audit form. You can see on the left it has the number of charts that are audited on a monthly basis. Across the top you will see 5 measures that we'll be looking at on our chart audits. First, age of patient and years. We want to include patients between ages 0 through 18 years of age. Number 2, type of visit. We would like to see a balanced mix of provider visits. So you would choose one, acute care visit, well child check, or medicine check visit. Measure 3, assessment of current immunization status documented, yes or no. 4A, missed opportunity at this encounter, yes or no. If no, you would skip measure 4B and move right to measure 5. If yes, was an opportunity missed due to the HPV vaccine only. And the final measure, measure 5, follow-up for next immunization documented, yes or no. Next, we're looking at chart audit guidelines for both baseline and monthly chart audits. For baseline audit, each practice will randomly select 40 patient encounters. Patients must be between the ages of 0 through 18 years of age. For monthly chart audits, each practice will randomly select 20 patient encounters. Again, those patients must be between the age of 0 through 18 years of age, and only 1 encounter per patient per audit cycle. Charts selected should be a balanced mix of provider encounters. If you are a family physician and participating in this project, each provider will randomly select and audit 20 charts for baseline and 10 charts per month. So what are your next steps? You will do a one-time baseline chart audit at the beginning of the Learning Collaborative. You will then do monthly chart audits throughout the duration of the project. You will also submit monthly progress PDSA forms. Lastly, we will have monthly technical assistance conference calls. In summary, after listening to this presentation, you should be able to answer the following questions. What is quality improvement? What is a PDSA cycle and how would you use it? What are 2 of the 4 core measures outlined for this project? How often are chart audits required for this project? And lastly, what project deliverables will your practice work on first?
This concludes this particular learning session. This would be a great time to work with your practice team and identify some areas to focus on and make changes for the future. Thank you.